always. And we always start with a tip of the week because some of us are too lazy to go back to school. And so Dr. Mario fills us in on what he's been learning at the Arizona Integrative Medicine Fellowship.
All right, so this topic is probably a good introduction for our ketamine discussion. And it's probably I always hear this from John. So, John Burgess, I hope you're here. You're going to be hearing this leak or tip of the week. I kind of dedicate this to you. So, today's topic is ibogaine. So, I was telling you in the University of Arizona, we're playing around with all of these herbs. And the last discussion that I had was kratom. So, now it's ibogaine. So a compound that is a good primer for our ketamine webinar and also a good continuation of our integrative cognitive herbal discussions, which was kratom the last time. So hippies unite, right? This is not an endorsement talk. It's a mechanism plus evidence update for clinicians who want to understand what ibogaine keeps resurfacing in serious research conversations. So ibogaine, let's start with the history from the root bark of Turbinanthe iboga shrub in native Central Africa is metabolized to noribogaine, which is a longer-acting metabolite. Has been used for centuries in traditional Buitri rituals for spiritual and initiatory purposes, inducing visionary states and serving as a rite of passage. In modern context, a pivotal moment came in 1962 when Howard Lotsof, an opiate user, discovered its potential to interrupt addiction, leading to a U.S. patent in 1985 for its use in treating opioid dependence. However, due to the safety concerns and lack of large-scale trials, it was classified as Schedule 1 substance in the US in 1970, halting mainstream research. It has a long half-life, up to 72 hours, and contributes to sustained effects. Effects onsets around 30 minutes to 3 hours post-ingestion, peaking in a dreamlike introspective state lasting 24 hours, following by reflective after effects. So low doses acts as stimulants, and higher doses are psychedelics. So it is polypharmacologic. NMDA antagonism, like where ketamine works, will be explained later on by Dr. Boco. A kappa and mu opioid receptor modulator, serotonergic effects, dopaminergic normalization, and even increasing neurotrophic signaling through BDNF, GDNF in clinical models. And clinically, this looks like a state shift rather than a single pathway intervention. So best evidence remains in addiction interruption. Ibogaine's primary investigated benefit use is in the substance use disorders, particularly opioid use disorder, where it rapidly alleviates withdrawal symptoms and cravings. Here's the thing, here's the clicker, in a single dose. So potentially resetting addictive pathways via neuroplasticity. So Marsh et al. 2018, there's an observational study that actually showed acute opiate withdrawal suppression, reduced cravings lasting for weeks to months. Effects even correlate with noribogaine levels. Brown and Alper et al. 2017 reviews of human observational studies showing decreased substance abuse, psychological insight and trauma processing, and highly variable durability. So TBIs and PTSD, a 2024 Stanford study of 30 veterans showed an 88% reduction in PTSD symptoms. So Jovel, I think, advocates for this 1 month post-treatment with improvements in depression and functioning when combined with magnesium for cardiac protection. So the safety problems with ibogaine is actually related to cardiac toxicity, particularly QT prolongation and ventricular arrhythmias. So important emerging work here, Stanford-affiliated preclinical trials and research explored magnesium co-administration to blunt the ibogaine induction QT prolongation. And magnesium appears to stabilize the cardiac repolarization pathways implicated in ibogaine toxicity. So key point here is this is experimental, not a green light. It highlights that risk mitigation is an active research area, not settled science. So ibogaine still requires EKG screening, electrolyte optimization, strict exclusion criteria, and administration must occur in supervised medical environments. So the emerging case reports in 2025 to 2026, MS. There are 2 patients treated in a Mexican clinic showed 71% lesion volume reduction, improved diffusion metrics, and motor gains. So it also demonstrated cortical and subcortical plasticity and functional improvement. For Parkinson's, a single case report, reducing tremors, improved motor control and quality of life, proposed mechanism, again, dopaminergic modulation and GDNF signaling. So this do not establish efficacy, but they reinforce ibogaine's neurocircuit modifying capacity. So takeaways, ibogaine is best viewed as a neuroplastic disruptor, not a longevity therapy, a high-risk, low-infrastructure compound, a window into what rapid neural reorganization can really look like. So again, ibogaine shows us what's biologically possible, not yet what's clinically scalable. So that's our leak of the week.
Well, I don't know what's going on down there in Tucson. Last week it was kratom. This week it's ibogaine. Can ayahuasca be far behind?
Hey, I can do one of those. But the thing here is why ibogaine was chosen. Ketamine also works in the specific pathway of the NMDA receptor. So maybe that's a good preview. And I said to you, this is dedicated to John, who
Well,
advocates for ibogaine.
uh, yeah, we're in the middle of the ibogaine for a long time. We have a clinic in the Caribbean and the Bahamas if you want to do it. It gets dangerous in Canada. It used to be totally legal. Now it's totally illegal. So something's going on with the whole and the government proved the ibogaine worked like 30, 40 years ago. And then they shut it up and sent the researchers to Texas and cut a deal. They are now the directors of the Brain Bank, the Kennedy Brain Bank in Miami. So anyway, the ibogaine's happening. We had a substitute herbal formula that cost about 1% as much as ibogaine. If we did ibogaine, it's $10,000. If we did the other formula we had that was developed on your West Coast there, we could get people off opiates, heroin, almost every time at 1% of the cost, under $100. Now, the people who manufactured and distributed that in California have been told to disappear, and they have, and the product. So it's not just that the ibogaine works, there are other things that work that have been suppressed. And as far as ayahuasca, the head of the Ayahuasca Church of Hawaii, which does it legitimately and ceremonially the way you should, because it should be done right and set and setting, be safe. I spoke to him and asked if he'd be willing to come to Reno and do a formal ayahuasca treatment there. And it's legal because the Supreme Court said so. And he's the head of the church and he does it right, I know. And if you guys want to do ayahuasca in Reno, we could probably do that. And it could probably be done right. It's not to be played around with. Thank you very much.
And if I may chime in real quick, Dr. Boco might know about this. The In Waves and War movie that came out a few years back is in connection to Marcus Capone, and Marcus Capone and his wife started the Vets and their Vets organization. I don't know if it was an offshoot from working with Stanford, but they now take mostly special operators to Mexico to do this treatment. MDMA and ibogaine was huge with their organization, but the Stanford pilot research project was three of them were the main characters, extreme multiple tours. And then there was a few others. They go through the, questioning and so forth and all that. But it was, I believe, like Dr. Nerio was saying, it was the ibogaine that was approved. And that is, I believe, what Stanford is studying. And I have a feeling Dr. Boco knows about it. So, and then I've heard that the VA in Georgia is doing psilocybin treatment. I don't know which one, but it's they're doing what they can as fast as they can, I believe. Kind of.
The ayahuasca treatment is very powerful, but if it's done safely and correctly with observation, it's very safe. And if you guys want to have the real deal, because the two plants that are mixed with the ayahuasca are grown in Hawaii, it's totally legal, and you could probably do it without having to travel, 28 people to Hawaii. It's a lot of money.
Agree.
All right, thank you. I'll be quiet.
All right. So we got
My kind of crowd.
yeah, there you go.
We got them all
you thought we were
wrapped
just
up.
a bunch of old frumps here, huh? That's what I'm saying. What's going on down there at that? Is that just a front, that fellowship down there?
Yeah, it's a drug ring.
Yeah. Okay. Well, always enlightening, Dr. Nario.
Ruffled all their feathers.
Yeah. So anyway, so our speaker this week is Dr. Erwin Boco. I apologize for the typos there in the headlines, but I did get it in. If anybody read the the bio, his bio, I did get it right there. A board certified family physician. He brings a deep commitment to whole person trauma informed care and evidence based innovation. He graduated with honors with Dr. Nario, apparently, at the University of Santo Tomas College of Medicine and Surgery in 2005. He was a family practice residency graduate at the University of Texas Science Center at Houston in 2009. He spent 4 years in private practice. He then joined the Kaiser Permanente, Northern California in 2015. He was a leader of leadership roles there on behavioral health, trauma-informed systems, and community advocacy. He was a clinical medical supervisor, a regional director for Northern California Family Medicine, Child Abuse Services. He was the program lead for intimate partner and family violence screening and program lead for adverse child events screening. In 2023, he recognized the critical gap in access to effective treatments for complex mental health conditions. He founded Zen Ketamine, an integrative treatment center providing evidence-based therapies for treatment-resistant depression, PTSD, anxiety disorders, and chronic pain. He completed an advanced fellowship training in ketamine therapeutics at the Integrative Psychiatry Institute. He's a member of the American Society of Ketamine Physicians, Practitioners, and Psychotherapists. And he likes yoga, meditation, consciousness, and self-awareness. He uses emerging neuroscience-based interventions and trauma-informed approaches to integrative medicine. So with that, Dr. Boco, thank you for being with us. We're happy to have you here. And again, I do apologize for the typo there. So I'll get it right the next time.
Thank you, Dr. Clearfield. Thank you, Dr. Nair, for the invitation. Happy to be here as a speaker to talk about ketamine and treatment-resistant depression. I just shared my slide, and I wanted to ask.
We're good. We got them.
Are you guys able to see it?
Yep.
All right. Let's go ahead. First disclosures, I have no financial relationships with any pharmaceutical company other than being the founder and owner of Zen Ketamine. Any patient information I may be sharing during this presentation is for educational purposes in compliance with privacy regulations. For our objectives, we're going to learn what treatment-resistant depression means. We're also going to learn more about ketamine today, background, history, how it works, and how we use it in mood disorders. For this particular talk, specifically in treatment-resistant depression. I'm also going to present some clinical cases that we share in terms of what our experience is in our clinic and some real-world data and outcomes. There's some really exciting data from established clinics that we were able to gather during the recent Global Ketamine Conference in Austin this year. So the problem of depression is a big problem. I'm sure all the providers in this room are aware of this problem. The prevalence has only increased after COVID from 19% to now 29%. It's worse in certain population groups. And usually there's overlapping comorbid conditions, anxiety, PTSD being the top two. Substance use disorders is also a part of it as well. And our younger population is not immune. We know, especially after COVID, that there's been a surge of mental health crises among our adolescent population. Special groups such as the LGBTQ are especially more susceptible. They're 5 times more likely to attempt suicides during the pandemic. We now have a high-level population-based understanding of how good we are or how limited we are in helping patients with treatment-resistant depression or major depressive disorder. In 2015, the largest population-based study, which is the SARD trial, was published through the NIH, and What we learned is that for patients that have true clinical depression, based on the best practices and clinical guidelines in practice that we use right now, the current best practice is we pair them with a therapist, and we usually start them with antidepressants. We now know that the response rates for the first time somebody tries an antidepressant is only about 27.5%. Furthermore, for every trial after the first one, we now understand that the response incrementally decreases. So for the second trial, after usually trying 8 to 12 weeks of robust timeframes and adjusting the doses to moderate or high doses, we give the patients a second trial of antidepressants if the first one doesn't work. The second one, the response decreases further to 21%. On the third trial, it further decreases to 16%. By the time the patient has a fourth trial of antidepressant, the response rate is less than 7%. And even if you add this all up, it's about 65% to 70%. About 30% of patients will not respond to our traditional approaches using SSRIs and SNRIs. And these cases we refer to as treatment-resistant depression cases. We also learned that it didn't matter who was prescribing the antidepressants. It could be the psychiatrist or the patient's primary care doctors. More than half of the patients with depression are being treated by their primary care providers in the US. And so it didn't matter. So this is a big problem. And I'm sure a lot of you are experiencing this in your practices, patients coming to you, telling you how frustrated they are. They tried multiple medications, nothing helped. They jumped from doctor to doctor. Nobody can help them. And they kind of surrendered and just kind of powering through life, which is really a sorry state to be in. The FDA defined treatment-resistant depression as failure to respond to 2 or more antidepressant regimens despite adequate dose and duration and adherence to treatment. Adequate duration is usually defined as a period between 8 to 12 weeks of trial, which usually is when the SSRIs and antidepressants are known to kind of peak in terms of response times. I'm going to share my first case. This is EF. He's a 40-year-old musician. He was referred by his wife because of a very long history of severe depression and anxiety. He lives in constant fear. He's always overwhelmed. Getting out of bed is a struggle. He has no appetite and has actually lost 15 pounds in the last year. When we saw him, he didn't have any active suicidal ideations. He did report having some passive thoughts that he had no intention of carrying out. He's tried multiple SSRIs over the past several years. I think he's tried over 7, cannot recall the names, and did not tolerate the side effects very well. He's had prior experience with ayahuasca several years ago and recalls and reports that he didn't like it because of the side effects. He was, I think, having some really bad vomiting that is usually associated with ayahuasca. And he reports that he felt great afterwards. And it lasted for a while until the depression kind of came back. He's also had prior history of alcohol addiction and drug addiction, including opiates, cocaine, methamphetamine, crack, MDMA. But he's been sober for 7 years, and he's attending Narcotics Anonymous and some support groups. Other than that, he's got a fatty liver, some elevated blood pressure, but never really diagnosed with hypertension. So when we started treating him, we started tracking his depression and his anxiety scores. So we usually use the PHQ-9 patient health questionnaire, which is a standard depression scale. There's many others that can be used, HAM-D, MADRS. We use PHQ-9. The colors on the top represent the severity of the depression. The bright red means very severe. Orange is moderate to severe. The middle yellow is moderate. The mild yellow is mild, and green is remission range, which is the goal that we'd like to hit. The vertical black lines represents the treatment of the infusions that the patient received. And the one on the bottom is the anxiety, and we use the GAD-7 scoring system to kind of track anxieties as well. And you can see this patient was an early responder, very rapid, very robust response. Even after just the first session, hitting into remission and going all the way down to 0 after completing his induction. This is kind of like a brief history of ketamine. It was developed out of tweaking with PCP back in 1962, when they were kind of tweaking PCP and developing PCP as a potential anesthesia medication. But it was very toxic, and so they tried to refine it, and ketamine was born. Patent was formed in 1966 and was started being used around that time. And then it was approved by the FDA officially as a dissociative anesthetic around 1970. And since then became generic and has been used in the surgery world as an anesthetic agent. And in late 1990s, that's really when, the first kind of observations of patients getting out of surgery, reporting that, hey, doc, my suicidality is better, my depression is lifted, my anxiety is better. That's when we started paying attention. And in 2000, Robert Berman from Yale published the first randomized control trial. And this was a landmark study, and it's probably one of the most referenced articles in the ketamine space. And he examined and randomized controlled experimentation, 9 patients, placebo versus ketamine controlled. And he gave only 1 IV infusion, measured their depression scores using the HAM-D questionnaires. And what he found was all of the patients that received 1 IV infusion improved their depression scores by greater than 50%. And that happened within a window of 72 hours after the infusion. So it was very rapid and very robust. And not only that, the response lasted for 1 to 2 weeks before the patient reported that the depression symptoms started to kind of relapse or recur. And since then, there's been a growth of bigger and bigger studies. And I think right now we're already sitting at over 160 well-designed, randomized controlled trials that are placebo-controlled, and some are specific to ketamine itself. Some are specific to S-ketamine, which is the intranasal version of the S isomer, as well. And there's some that uses other modalities like oral ones, as well. And depending on which studies you look at, the response rates are pretty impressive. And so some would report somewhere in the range of 65% response rates, some in the 85% response rates, but they kind of fall around this general number of around 80%. And so this is kind of like the general accepted response rates within the ketamine specialty community. In 2021, our friends at the North, our Canadian friends, formed a task force to do a systematic review of all electronic database researches that is available, which is the Canadian Network for Mood and Anxiety Treatments Task Force. And not only that, they kind of categorized the medical evidence into different tiers or different levels. Level 1 being the highest level. And what they found was, among the data that they found, what was consistent is that even just one single IV ketamine is a level 1 evidence for efficacy in adults with treatment-resistant depression. They also look at studies that use multiple infusions, and it showed a level 3 evidence, which is still pretty good. Then they looked at other trials that are non-IV treatments, so non-IV formulations. So some are intranasal, intramuscular, some are oral. All other trials were categorized as level 3 and level 4. When they compared single versus multiple infusions, they found that those that received multiple infusions had higher response rates and higher remission rates than those with single infusions. In 2015, there's a large VA study by Dr. Sophia Albert in the Midwest. I think it was in Indianapolis. And she specifically was interested in using IV ketamine for veterans with major depressive disorder with a comorbid PTSD disorder. And what they found was pretty impressive. for some reason, if a patient has both MDD as well as PTSD, two very complex cases in the same patient, it seems like the response rates was actually higher. What she found was that the response rate for TRD was 93.3%. And in about 80% of these patients, the PTSD went into full remission, which kind of led into the eventual adoption of IV ketamine into the national protocol and clinical practice guidelines for the VA as part of their tools in helping veterans with treatment-resistant depression and severe suicidal ideation. So the VA was the first government institution to recognize its value and has since then included it and actually covers the treatments 100%. So like we're in contract with the VA and we're proud to serve our veterans. And it's really cool to see the VA kind of step up in this space and cover these treatments for our veterans. Since then, I think this clinical practice guidelines, and it's public information, you can Google this. This is usually updated over a few years or so. The most recent update was last October of 2025 and has been the basis of a lot of other advancements in terms of policy making and just increasing the dialogue and awareness, in the field. 2 years ago, the Colorado Medicaid started covering IV ketamine as well in that state. So we think that the arc of movement is towards adoption. And once Medicare grandfathers or decides to cover it, all private insurances should cover IV ketamine. Right now, because it's considered off-label, most commercial insurance don't cover ketamine treatments right now. The current gold standard for treatment-resistant depression is electroconvulsive therapy, which has been around for 6-7 decades, but has not been well adapted because of several reasons. Stigma from patient perception, side effects, high technical need in terms of training. So because you have to be associated with the hospital, and it can only be done in a hospital because you have to be sedated, for ECT or conscious sedation. So in 2023, it was challenged, which has not been challenged in a long time. So it was the first time it was challenged in a long time. It was called the ELECT-D trial. So electroconvulsive therapy versus ketamine in treatment-resistant depression. And it was a big multi-center trial that involved Baylor College of Medicine, Johns Hopkins, Cleveland Clinic, Mount Sinai, and Yale University of Medicine. And it was an open label, randomized, non-inferiority trial. They wanted to see if it was inferior to ECT. And the design of the experiment actually had a special bias for ECT because the patients that was selected was already under the notion that they were going to get ECT. It was just that they were given the option to try this other alternative treatment option. What they found was ketamine is not inferior to ECT. And in fact, it was found to be superior in 3 out of the 5 centers in measuring the primary outcome, which is the improvement of the depression. And the secondary outcome was actually a measurement of the side effects. And they found that IV ketamine did not have any of the side effects usually associated with ECT. And usually it's cognitive issues, memory loss, and focus and concentration. And up to date, for the last 30 years, ketamine has been the most extensively researched antidepressant by far. Case 2. So we have a retired 68-year-old female who's had a long history of depression that's been categorized as treatment-resistant since she was 18 years old. Had a lot of abuse growing up, also had PTSD, also have history of substance abuse, but has been sober for the past 6 years. Has good support in Narcotics Anonymous with the church and support meetings, as well. She's tried multiple antidepressants, 1, 2, 3, 4, 5, 6, 7, 8, more than 10, and in robust timeframes. But when I saw her current antidepressant regimen at the time that her psychiatrist put her on was duloxetine, and she was taking 60 milligrams once a day. And she started this from 2 years ago, and she reports, like most patients, it kind of helped, but it didn't really significantly lifted her depression. She also tried TMS before, which is transcranial magnetic stimulators, and these are one of the newer treatments that we have, in the psychiatry space, as well. That's non-invasive interventional psychiatry treatment. But it didn't help for her, and she's been on and off therapy for many years. She doesn't have very great family support. She's divorced, lives alone, but she's active in church. When we started treating with her, within 4 weeks, she achieved the remission range, which was amazing. And she's a good demonstration of somebody who has PTSD that also had great response, with her PTSD. We measure PTSD with PCL5, which is a robust questionnaire that has specific questions regarding hypervigilance and hyperavoidance symptoms. A score of about 33 to 35 is about moderate. 60 for her is very severe, and it went down to 9. So very, very mild, almost close to remission. Very life-changing for her. So what is ketamine? Ketamine, it's an old drug that was approved as an anesthetic, back in the 70s. It's made up of 2 6-carbon rings, the cyclohexone ring with the ketone over there, and the chlorophenyl ring with the benzene ring over there on the top. And then you have the phenylamino handle in the middle. And in nature, all molecules have, isomers, so chemical isomers. So you have a right and a left side mirror image, or the dextro and the S isomer. And racemic ketamine is equal parts 50% right side and equal parts 50% left side. And that comes into play because later on, because it's such an old drug, a generic drug, a cheap drug, there's no financial incentive for any pharmaceutical company to kind of take it on and do the formal FDA 3-phase clinical trials, to try it on for a new indication other than anesthesia. So in this case, either mood disorders or chronic pain syndromes, because we also use it for chronic pain syndromes. But Janssen in 2019 was able to separate the right and the left isomer and isolated the S isomer, the left side isomer, packaged it into a nasal spray and, S-ketamine, and the brand name is Spravato. And now they are able to give it and covered by insurance, although it's a very, very, very expensive drug. It crosses the blood-brain barrier very easily, and the half-life is very quick. It's about 7 to 15 minutes. So the liver is the main organ that breaks it down. So it's very efficient in breaking it down. So much so that oral versions of ketamine, the bioavailability is only 10%, because the first liver pass, the liver destroys 90% of the medicine. And that's why IV is superior, because we bypass that and we get the bioavailability up to 100%. Intranasal is about 15 to 48% bioavailability. The intramuscular is about 90 to 95%. CYP inhibitors like grape juice can kind of slow down liver metabolism, so it can kind of increase, your levels and recovery times, as well. But most patients, after we stop the infusion pump, usually, it's no longer in the bloodstream within 7 to 15 minutes, even though the mind is still kind of having, an experience. And it takes another 20 minutes for them to kind of have a soft landing back, to their pre-treatment state before we safely discharge them after assessing that they are safe to be discharged within about 30 minutes after we stop the pump. And then it's after being destroyed in the liver, it's eliminated and excreted in the kidneys and in the urine. And hence that kind of bladder irritation phenomenon that we usually see, more so in the oral vehicles, not so much in the IV, because we don't use very high doses in the IV because we get to the 100% bioavailability dimension of it. One way that oral formulations bypass that is really increasing the oral doses to have higher levels reach the brain. But as a consequence, higher doses also get to the bladder, and that's when you get into problems of like bladder ulcers, bleeding, ulcerations, and whatnot. There's different ways to give it. IV intramuscular, you get the esketamine intranasal. You get some compounded intranasal versions as well that can be done by compounding pharmacies. The one that's branded FDA approved is created by Janssen. And then you have the oral versions, rapid dissolving tablets, troches, capsules, tablets. There's some subcutaneous ones and some patches, but they're really not worth mentioning. Different modalities can get you into different outcomes. In our treatment center, we focus on the best outcomes. And so that's why we only offer these 3 modalities. And out of the 3 modalities, we really focus on IV or the intranasal version. And the reason for that is that it doesn't really make sense to get the intramuscular version if you have access to the IV. There are some special considerations in patients who are, for example, cancer patients who may be hard sticks, or patients with needle phobias that they don't like the idea of having an IV catheter sitting there. So intramuscular might be a good option. So in our clinic that's been running for a couple of years, I've only maybe had 2 patients do intramuscular injections. And this is just really to kind of like visually separate the difference between the 2. I would think of esketamine as kind of like a derivative of the original IV ketamine. It's the left side version of the IV ketamine, which has both right and left side. The cool thing about it is that because it's FDA approved, it's covered by insurance, but it's only FDA approved for 2 conditions, which is 1, treatment-resistant depression, and 2, suicidality. So you can't use it for PTSD, can't use it for chronic pain, can't use it for anxiety, can't use it for other mood disorders. But for IV ketamine, because we're using it off-label, we just follow the evidence. And so we have greater flexibility in terms of conditions that it has demonstrated to provide response and value. When the FDA approved the esketamine in 2019, it was approved as an adjunct to antidepressants, which means that you have to take it with an antidepressant maintenance medication. Last year, in January, it was approved as the first drug and only drug approved for treatment-resistant depression as monotherapy, which is a big, big deal. So ECT even requires, antidepressants adjunct. TMS requires antidepressant adjuncts. And so it has demonstrated a great response that for patients that have tried, 10, 15, 20 antidepressants, does not want to be on antidepressants anymore because of side effects or intolerability. We now have the option of either weaning them off and just be on the esketamine as a maintenance medication. The old kind of understanding of depression as solely a chemical imbalance problem is no longer sufficient. We now believe that there's also a wiring problem. In patients who suffer from depression, when they do autopsies, we find that the brain mass is actually smaller by almost up to 30% in some cases. And at the cellular level, what we find is that the branches, the dendritic spines in the secondary branches are either decreased in girth or kind of less, as well. And we know that exposures to chronic stress, chronic toxic stress, chronic trauma can also cause a phenomenon called dendritic pruning. And so damage is happening, in the brain. This slide, I just wanted to kind of demonstrate in a simple slide how ketamine works in the brain, and we'll deep dive a little bit into some of the chemistry. So ketamine, either by any modality, IV, intramuscular, intranasal, eventually gets to the brain and attaches to the NMDA receptor on the inhibitory neuron that kind of controls whether glutamate is going to be released or not. Once ketamine attaches, glutamate is then released from its presynaptic vesicles, flooding the extracellular space, and now has the opportunity to interact with the receptors of the postsynaptic terminals. Okay, and glutamate is very different from serotonin. And just to give you an idea, your brain produces a lot of beautiful neurotransmitters. Serotonin is responsible for mood regulation, and it's about 2% of what your brain produces. Glutamate is also responsible for mood regulation, and it's about 70 to 80% of what your brain produces. So it has reach. Okay, so and the current kind of understanding in patients with treatment-resistant mood disorders, PTSD, depression, or anxiety is that we have several mood centers in the brain. There's no just one area in the brain that's located, and we say that's a problem with the mood. You actually have several. You have several mood centers in your lower animal brain, your limbic system. You have several mood centers in your higher levels of the brain, your prefrontal cortex. You even have several mood centers in your brainstem, as well. And the current understanding is that these mood centers are either dormant, lazy, not functioning 100%, or sleeping. And what happens when glutamate is released is that it wakes it all up, and it does it very rapidly and very quickly. There's several receptors in the post-synaptic terminals, AMPA, NMDA. You also have NMDA receptors in that postsynaptic terminal. You have BDNF receptors. And ultimately, and this is a good kind of a boring slide on the biochemistry aspect of it, but if I can get you excited about this picture, this is it. Okay, because once ketamine is activating and releasing the glutamate, it activates all of these receptors on this wall. That's a vertical wall, your NMDA receptors, your AMPA receptors. Opens up your calcium channels that causes depolarization of the cellular membrane, that leads into intracellular signaling with your protein kinases, elongation factor 2K, your BDNF, your AKT, ERK. All of this is just designed to reach mTOR. Okay, and I want to just pause there, because what I've just explained to you is that ketamine is just really a high-level signal to try to reach mTOR. Okay, and that's the central message. Okay, because once mTOR is activated, that is it. So we want to reach mTOR because mTOR is the growth switch. Now, mTOR is present in all of our cells, including the brain cells. I think a few months ago, there was a gentleman that gave a talk about longevity, aging, and rapamycin and how it affects mTOR. mTOR means mechanistic target of rapamycin. So this is the one that's being targeted by rapamycin in the longevity space, in the aging science space, and they try to switch off mTOR because when you do, it forces cells into autophagy. And so, but in this case, in the brain, you actually want to switch it on. And I think this is the counterbalance to that kind of understanding, and brings the yin to the yang of all of our human experience, where it really depends on the situation and what your needs are. And so there are certain situations where you want to slow down mTOR. There's certain situations where you might want to activate it when you need it. Similar to athletes, there's a good question. Is a fast heart rate important? Well, it depends. If you're resting, you want a slow heart rate. If you're exercising, you want a fast heart rate. So the athlete, the very good athlete, can control both, right? And so it's the same thing. So mTOR, once activated, it's a protein, but we also kind of look at it as a pathway, because it just kind of activates all these beautiful growth in the brain cells. It forms new synapses, new dendritic spines that helps grow and connect. The ones that are kind of weak, it helps make it stronger. Okay? It repairs it, it rebuilds it, okay? And it helps with improved mood and thinking. Because if you have better synapses, think of your brain cell, it only has 3 branches. It can only connect to 3 other brain cells, process and communicate. And tomorrow, it now has 12, branches. So it can talk to 12 other brain cells. So perception can change. The way you find meaning in things can change, as well. Okay, so mTOR is the main kind of foreman in the construction of the brain cells, and actually in all cells. And so when it is switched, it's like the analogy I heard that was beautiful is like, if there's a storm that damages your brain or damages a city, roofs are toppled, bridges are destroyed, trees topple down. your antidepressants are like the small crews coming in and doing nail work and patchwork. mTOR is like the big contractors. They come in, they can build a bridge in a day. Okay, that's how big and fast mTOR acts. So mTOR is it, and this just kind of brings it all together. Ketamine being a high-level signal that tries to reach mTOR through glutamate surge, and the glutamate surge reaches your postsynaptic terminals and activate some of the receptors there, NMDA, AMPA, and actually, their NMDA and AMPA are not separate receptors that work separately. They actually work together, and that leads to intracellular protein kinases getting activated. That leads to the mTOR getting switched on. BDNF protein receptors are getting activated. That further amplifies mTOR activation. That leads to all of these beautiful things happening. And we see it. So in clinical studies, we found that one IV infusion can stop suicidality within 4 to 5 hours. Brief stop. And in some emergency rooms in VA hospital in the Midwest, they already have protocols for IV ketamine for suicidality because it's quicker than waiting for your admission room. Okay, and they last 7 to 10 days. The whole premise of the old problem of why we try to keep patients on hold, 5150s, is because the old tools that we had, SSRIs, takes so long to kick in. That's why, we have to keep them for a few days. Now, some of you may have alluded, to some of this, but I just wanted to briefly mention this, and this will all kind of hopefully tie down and kind of combine everything. There's another receptor in the postsynaptic terminal that is very powerful, and it's your serotonin 2A receptor. There's different kinds of serotonin receptors. You have your 1A, you have your 2A, you have your 2C, your classic antidepressants, your Prozac, your Celexa, it usually blocks your serotonin transporters. And what happens is that it increases your serotonin in the extracellular space, and they have a special affinity to the 1A protein, which is different from the 2A protein. The 2A protein of the serotonin has two arms when it's activated. One is the psychedelic pathway, which leads to cortical activation, excitation, and hyperarousal. And this is where the psychedelic pharmacology happens. And the second one leads to mTOR. Okay. And what are the strongest serotonin 2A receptors that exist? Your classic psychedelics, your ayahuasca, DMT, LSD, ibogaine, which is 5-MeO-DMT, right? So, and there's even studies about ayahuasca having a greater window in terms of mTOR activation, in terms of neuroplasticity, longer than ketamine. So the window for ketamine is actually within the neuroplasticity starts 24 hours after one infusion, and it continues for 72 hours. In ayahuasca, it can be 2 months with one treatment. And in some reports, it has been shown to even extend up to 15 to 18 months in some cases. Okay. So this is where there's a parallelism between ketamine and your classic psychedelics, because they both kind of try to reach mTOR. And the key thing to kind of remember here is that while they have some similarities, they're not the same. So ketamine does not have any action to the 5-HT2A, serotonin 2A receptor. There was initial kind of theories that it might have a weak serotonergic effect, a weak dopamine effect, but now we know there's not. The way that ketamine kind of has that psychedelic experience is not the same as classic psychedelics does. So the way classic psychedelics provides the psychedelic experience for the patients is through activation of the psychedelic receptor, 5-HT2A, that leads to the excitation through the psychedelic perceptual arm. Ketamine does it through high-level, large-scale brain network disruption, through the default mode network, through the salience network, through thalamocortical gating and prefrontal limbic coupling. So even though you have psychedelic phenomenology, It's not the same as psychedelic pharmacology. And this is really where the purists will say ketamine is not a true psychedelic. It's a dissociative agent. But they do share that the common trait of trying to reach mTOR, and that's why you see the same kind of improvements that you see in mood disorders, in trauma with the use of psychedelics, because they both activate mTOR. Okay. And there's a lot of more proteins of research and kinases that happens at this level. Some people pour their whole life energies researching just one protein, one receptor, NMDA receptor, AMPA receptor, and that would have been a well-lived life, just so we can have a better understanding of how this whole cascade benefits us and our patients. How much glutamate is good in the brain? We know that there's an optimum amount. We don't know exactly. It's not a number. We know too little is not good. We know too much is harmful. Too much glutamate actually harms the brain and destroys, the brain cells. And it's not just an amount. It's also in terms of how efficient is it being recycled, how strong is the glutamate affinity to the post-terminal receptors, how strong is the signaling. Because, for example, NMDA receptor, we assume that there's only one form of NMDA receptor, where there's actually 43 different variations of the foldings of the NMDA. And depending on what genetic tendency you have, it will dictate how strong, glutamate will attach to that NMDA and lead to downstream signaling, whether it's going to be weak or strong signaling. We have some unexpected players that help glutamate modulators, that modulate glutamate. Roy published last year that there's a lot of GLP-1 receptors in the brain, located in the hypothalamus, brainstem, cognitive centers. And so with the kind of growth of the GLP-1 industry, Ozempic, and all of these other weight loss medications, patients are reporting that they're having mood improvements as well, and it's separate from the weight loss, and this is why. And it acts the same thing, and so the glutamate is released, it increases neuronal activity, also helps with dopamine signaling, it prevents synaptic loss, and helps with neurogenesis, and regulates mood and reward systems. What's another NMDA receptor molecule that that's been around for such a long time, right? Nitrous oxide, laughing gas. So there's been several studies that show, and actually it's re-emerging. I've been to a ketamine conference, and they have some people that are offering nitrous oxide, as an alternative. There's studies going on right now. There's already studies that have taken place that demonstrates, improvement in mood, depression, with patients given just 1 hour of nitrous oxide versus placebo. Okay, and there's some historical reports. I think I read a few years ago, back during before World War II, when the British was in Africa. There's a lot of increased dental visits from the soldiers because they wanted to get their nitrous oxide because it helps fight loneliness and sadness and depression while they were away during that time. So the neuroplasticity happens very quickly. This is my study by Wu that shows within 24 hours, you have buds growing already. And the growth continues to happen for the next 72 hours. This is pre and post. The yellow arrows are the new dendrites forming. And it stacks and it builds. So for every treatment you have, it builds from the previous one. A very curious phenomenon happened when the brain cells are exposed, to toxic stress. It's called dendritic pruning. And so the branches whittle out, there's less branches. The main branch kind of thins out, as well after exposure to chronic stress. 2 years ago, it was the first time I heard during the American Society of Ketamine Physicians conference in Austin that ketamine was dubbed as the first resilience drug. They actually presented some clinical experiments having some patients who worked in high stress environments, law enforcement, first responders, military, ER nurses, and placebo arm and 1 IV infusion arm. They followed them for 12 months, measured burnout rates, anxiety, PTSD, depression rates. The one with the placebo arm had higher burnout rates, anxiety, depression, PTSD, and the ones with just 1 IV infusion stayed flat the whole time, which was amazing. But we're not there yet as a treatment recommendation. So right now, we recommend ketamine as an option, as a third-line option. So patients should demonstrate to have tried at least 2 or more prior treatment trials first. There's a few exceptions. Suicidality is one of them, so you can skip the line. You don't need to try because obviously of the severity of the condition. And then law enforcement, military, space, because that whole space, it's just a tougher population. They don't like to talk about it. They don't like taking antidepressants because they don't want to be seen taking antidepressants. They will be judged. There's fear of judgment. Their judgments will be questioned, promotion stymied. So it's a very difficult space, and they probably need the most help, too. I've attended some of these first responder conferences. And so for those special cases, we can offer IV ketamine as a first option. Case 3, 53-year-old pastry chef. She has a history of longstanding treatment-resistant depression, also has severe anxiety since age 26. Severe anxiety seems to be a predictor of less response in some patients, especially the really, really severe ones. And it has been worsening for her for the past 6 months. She doesn't want to go to work. She also has rage. There's some family dynamic and some trauma with the family going on, and repeated exposure still. She's tried multiple antidepressants in the past, with several more that she can't recall, including fluoxetine, escitalopram, venlafaxine. She's currently on bupropion, 300 milligrams, but hasn't significantly helped. She's tried CBT, IOP, intensive outpatient programs, integration. She had a remote history of attempting suicide when she was 15 by overdosing on pills. She was finally referred to us by her psychiatrist for treatment-resistant depression because nothing worked, and the worsening of the symptoms. When we saw her, she was in distress, but she wasn't suicidal. She was unkempt, disheveled, flat affect. She was accompanied by her husband, and the husband was worried and concerned because, in his words, I feel like I'm losing my wife. Okay. So we started her right away with IV induction series, and the first thing we noted was from the very severe depression and anxiety symptoms, it went down to the moderate range. And then she continued on to do weekly boosters for another month. And then we transitioned her into esketamine or Spravato because that's it's a better long-term kind of sustainable option because it's covered by insurance. And, when they say that healing is not a straight line, this is a good kind of example case for that. It took her longer than other patients. But after 6 months, from April to about December, she finally reached remission, and that was a joy to see. So sometimes I see these like ups and downs. Part of it is because it's a complex case. Part of it is because some patients, you need to understand, they're still kind of exposed to some of the triggers, some of the stressors. Some can be from family members, some can be from work situations, and they need help kind of processing that, but sometimes they can't incorporate new strategies if getting out of bed is a struggle. So one of the key things that ketamine does is that it can change their state very rapidly so that they can at least have the capacity to have better problem solving to their situation or be more open to lifestyle changes, wellness changes that helps build that resilience over time. And so now she's taking Korean chef pastry classes. She's hiking, she's traveling, husband's happy with the outcome, and just maintaining treatments. Our protocol for treatment-resistant depression is based on some of the more refined protocols provided by ASKP3, IPI, and the CANMAT VA clinical practice guidelines are also included there. Patient selection, inclusion, and exclusion criteria is important. And so I mentioned, the right patients, those that are considered treatment-resistant depression and has failed 2 or more prior treatments. It's important to be clear about that, with a few exceptions I mentioned earlier. Pregnancy is a contraindication. Positive psychosis symptoms, schizophrenia, schizoaffective, mania, active mania are all contraindications. Ketamine wakes it up, makes it worse. And so we can't have those. Patients who've had prior severe allergy to ketamine from prior surgeries are also not good candidates. Ketamine is unique. It's one of the anesthesia agents that, even if you put patients to sleep, you don't need to put a tube down their throat, because it can maintain their hearts pumping and their lungs breathing. But it can overdo it, and so it can increase, blood pressures. So those with brain aneurysms, history of intracranial bleeding are contraindicated. Severe uncontrolled hypertension, we tell them to get that under control with our PCPs first. Those with unstable, uncontrolled substance use disorders are also excluded, although it's not an absolute contraindication. If they're stable, some patients have complex backgrounds, we do take them. And there's great data in its use in addiction medicine. So it helps with alcohol abuse, hard drug abuse, opioid disorders, opioid use disorders as well, even cannabis use disorders. And we've seen great success in some patients where we focused on the mood disorder, but the natural progression is that dimension of their case just naturally kind of improves and resolves as well. Because the liver is the main organ that eliminates it. So we do check for the liver function test. And in some patients with liver disease, we need GI clearance. The severe liver disease, Child-Pugh type C, are contraindicated because longer recovery, they can be in a deeper kind of state, and medication dose adjustments. So we check liver, kidneys, urine drug screen, pregnancy test for childbearing age women. And because it's a class 3 controlled medication, we also routinely check the cures report or PDMP reports with the DOJ. So the protocol is a series of 6 IV infusion treatments that is given more frequently during what is called the induction phase. And the recommendation is to give it in non-consecutive days. So usually twice a week or 3 times a week in some patients. But most patients, because of transportation, childcare, it's twice a week. We start with a starter dose of 0.5 mg per kilo, and we infuse it over 40 minutes. And then based on the first treatment, depending on how they respond, and most patients usually tolerate it very well, we can jump into the sweet spot range between 0.7 to 1 milligram per kilo. And within that space, we can infuse it over a period of 40 to 60 minutes. The way I like to do it is I start with a 0.5 on the treatment number 1, infuse it over 40 minutes. Treatment number 2, I can jump up to 0.75, still over 40 minutes. Treatment number 3, I stay at 0.75, but I push the duration to 60 minutes. And then treatment 4 to 6, I can kind of titrate up or down depending on patient tolerability, physiology, vital signs, and intensity of dissociative experience up to 1 milligram per kilo. In some cases where I've reached the ceiling and I feel like the response is partial or not quite there, we can actually individualize the treatments and increase to 1.25, 1.3, 1.5 even. The highest we have in our clinic is about 1.75 mg per kilo. We avoid 2 and above because that's the anesthetic range. So that's not appropriate for an outpatient setting. And the scheduling, like I mentioned, twice a week for 3 weeks. After they complete that, they move into the optimization or booster phase of once a week for 4 weeks to complete a series of 10. There's a lot of data that if you complete the 10, it pushes the response rate even higher, up to 85 to 87%. There's the data from Florida, 10,000 infusions, over 1,000 patients that demonstrated this. And then after that, they graduate for the IV. And it becomes individualized. Some patients, they don't need treatments anymore. They're living their best lives. Call us as needed if you need it. Some patients with complex cases, they do need some maintenance. If you're a patient with severe depression, PTSD, first of all, you'll notice when you're better because you've been living with that condition day in and day out for many years. You'll also know when it starts to creep back up, and that's when they start calling us. It could be once a month for some patients. It could be every 2 to 3 months in some patients. Oh, before we discharge the patient, it's a whole kind of protocol. We have to observe them for a minimum of 30 minutes, and we assess their wakefulness. There's a RASS scoring that we check. Patient cannot drive and needs a responsible adult to pick them up. They can also use rideshare, Uber, and Lyft. And the recommendation is they can return to driving the next day after a restful night's sleep. We use infusion pumps. Some clinics use drips, bags. We have experience enhancers, recliners, eye covers, psychedelic lights. We can black out the rooms. We have pre-warmed blankets. Patients love those to the degree that the patient prefers. Okay. We do continuous vital signs monitoring, blood pressure, heart rate, respiratory rate, O2 sats, and in some cardiac patients, AFib, tachycardia, some patients with some other heart conditions, we do continuous EKG as well. These are some of the potential and transient side effects, potential because not everybody will have them. Less than 5% maybe in some cases. Transient because if patients experience them, it's in the context of the 2 hours that they are getting the treatment. Dissociation, as I mentioned, is this experience that the patients have that they feel like out of body or light or floaty or dreamlike. Most patients describe it as peaceful, calming, and relaxing experience. Most patients actually like this and they welcome this and they look forward to this aspect of their experience. Less than 5%, it's so unfamiliar to them that they might find it unpleasant. I always tell patients, you're awake, you're aware. You have power, control, and influence in how to steer your mind if it's trying to take you down a path, maybe of an old memory and old trauma. The doses that we use is 10 times less than what we would normally use for surgery. So patients are awake and aware, but their senses are like hyper. They are hypersensitive to their sensory input. Cognitive and memory, some patients, because of the effect of glutamate, they feel like they're so sharp, they're so focused. They tell me like, doc, I feel like I can compete, in a quiz bee. And then you have some patients that feel like there's a lot of cognitive loading that happened and they just feel like their brain is tired and they just want to rest their head, like similar to after you finish studying for a finals exam. We measure their blood pressures because it can sometimes transiently increase. And when it happens, usually it happens around the 40-minute mark. We do have some medicines, labetalol, hydralazine if we need to, if it goes into the emergency range and it doesn't go down. Our experience is usually it's transient, lasts maybe a few minutes and it goes back down. It can activate the bladder, make patients feel like they need to go pee. We haven't seen this as a problem. If we really have to, we can stop the pump and disconnect the IV. They can go, come back, reconnect, and pick up where we left off. It becomes more of a problem in chronic pain protocol because the chronic pain is actually a 4-hour infusion within a 6-hour visit. But we take breaks. Less than 5% can have nausea, vomiting. We give IV Zofran, and that usually takes care of it. Less than 3 to 5% might have mild headache. Nothing Tylenol or Motrin can fix. We check the liver, like I mentioned. And in some patients with sleep apnea, they can get relaxed where the O2 shows desaturations. We just tell them to bring their CPAP machine on the next treatment. That usually does the trick. All right, I'm almost done. So I just wanted to share some real world data. This was data from Sao Paulo, Brazil, one of the more prominent and large ketamine centers there. They've been tracking ketamine response in Brazil. And this one in particular was a study they presented in this year's conference in Austin for the American Society of Ketamine Physicians. And the focus was suicidality and depression. And so what this shows is that over time, the more infusion the patient has, their PHQ scores particularly question number 9, which is a question about self-harm and suicidality, has been decreasing as positive over time, where it's almost not there after 3 months of treatments. Harvard presented their first kind of data. So they've been operating since 2018. Dr. Kreitzer is running their clinic at Mass Gen Brigham. And we were really excited that they presented their data. And it was great. It was reassuring. So they first started as a kind of like a cash clinic, and then eventually they were able to make it so the insurance covers their treatments. And I think part of it is subsidized by the hospital. They've had a total of 471 patients. It's like a suite with like 9 gurneys and curtains. So not the best, enhanced experience like most clinics does or offer, but they focus mainly on cost and access. And they have about a 3 to 6 week wait time. And so they do see sicker patients, and part of that is probably because of the wait time. So patients are already kind of like in a bad state, and they have to wait 6 weeks to get treatment. So they're in a worse state by then. And this was a graph of the average treatment each patient received. Some patients, most patients receive somewhere between 6 to 10 IV treatments, and some receive as much as 80. And it could be a variety of reasons. Some could be better after 6 or 10. They don't need any more treatments. Some are more complex cases that they need more, after even completing the 6 to 10 series. This is the dose ranges that they gave. They all started at 0.5, and gradually they actually used higher doses. They went, the average was 1.3. The highest they would give is 1.5 mg per kilo, and they would infuse this over 40 minutes. So they didn't give 60 minutes. It's all 40 minutes. And again, it's just prime real estate for them. They want to try to accommodate and see as many patients as they can. They use QID scores, which is a quick inventory for depression symptoms. And they kind of measured what's the QID scores for the patients on the first visit versus the sixth visit. And they found a shift to the left, so the QID scores were decreasing. The average was around 16 to 17, which is severe in QID scores. And then it went down to about 9 to 10. And you see the overlap there on the left. And the average scores graph down in the linear graph. So we see this phenomenon. It's called the plateauing. So we see this initial response, and then it kind of flattens out. And so that can happen in the moderate or in the mild range in some patients, but we do see that phenomenon. So when I see that in a patient who was initially severe and now down to moderate, I can either escalate that and partner with a TMS, because TMS and ketamine can be synergistic, or offer other modalities as well. This is cost dependence and addiction. And so this was a graph by Gable, profiling all medications and their addictive and dependence potential, the highest being heroin. Ketamine is low, and it's actually lower than caffeine. Okay, so as you can see there. And being an integrative medicine, what are natural ways that we know that modulate glutamate? And so as we know, ketamine is just a tool that we use to try to activate glutamate, which is the spark that kind of starts it all, and in trying to reach mTOR. No surprise there. Exercise, So exercise in short periods of exercise has shown to demonstrate increased glutamate levels in your brain, okay? But it's a little bit more nuanced than that, because what we found in like consistent exercises in high performance athletes, their baseline glutamate levels are actually lower. And so there is this duality in how it behaves. And we think, in short bursts, it's helpful. But in kind of like training your brain how to use and release glutamate, how to recycle it, how the receptors are either resistant to it or has a strong affinity and strong signaling to it, plays a role, okay? Meditation, is another one. So we found that in patients that practice meditation over time, glutamate levels in parts of the brain can be lower as well. It goes back to that graph, right? Too much, too little, and the Goldilocks spot, the sweet spot. Okay, so amounts is not just the key here. It's how efficient are we utilizing the glutamate levels? Similar to metabolic disorders and diabetes and insulin, you have sensitivity. They even studied long-term Zen meditators, or long-term serious meditators is another term. They also found glutamate levels to be less. So there's another Sri Lankan study. So in our clinic, we do what's called social prescriptions. So when patients starts getting better, we give them a prescription to start meditating, or start walking around the block, or start eating an apple a day, or start making new connections, deeper connections with family or friends, because it helps them in their integration back into being able to let go of old programming, but also introduce new resilient building programming. Sleep is a great glutamate modulator, and in patients who have insomnia, they have this imbalance between excitation and inhibition of the neurotransmitters that leads to maladaptation of the neuroplasticity that happens in the brain, and so sleep is very, very important. Okay. And in patients with insomnia, they actually have very high levels of glutamate in the brain. And so, like I mentioned earlier, too much is also not good, because it can cause brain damage, brain cell damage. I'm going to briefly this slide just shows some of the newer modalities. The message is that there's hope if you're struggling from depression and you haven't, received treatments that worked. There's newer therapies like the glutamate-based therapies, such as ketamine or S-ketamine. TMS is another one. But there's some new exciting things in the horizon. Membrane receptor modulators and plastogens. And this is one example. I have to disclose, I don't own any shares or part of this company, but this is just to show you what's coming. Remember the receptors on the postsynaptic terminals below the ketamine activation that I was sharing earlier, the AMPA, the NMDA, even the serotonin 2A receptors. So the research going on right now is already at that level. And the molecules they're trying to create are novel, and they have what's called selective agonism, or functional selectivism, which means that they can activate the serotonin receptor, not activate the psychedelic arm, and go straight to mTOR. So this particular medicine just finished the phase 2 clinical trials, and it's a selective agonist on the 5-HT2A membrane receptor that can activate the mTOR arm without activating the psychedelic arm. So you don't have any of these psychedelic experiences. And it's a pill form, and there's only 2 doses. So you take it 4 weeks apart, and the durability of the response, meaning how long it lasts, is 12 months. And they're beginning the phase 3 clinical trials later this year. And there's, I think, 4 or 5 other medicines coming in the same class. One is the cycloserine, and these ones are targeting NMDA receptors specifically with some selective agonist properties, NRX 1074, which is apomosinil, and zolquistinel. So these are all, they just completed the phase 2 clinical trials, and they're all kind of promising and positive responses. So I think that's it. Thank you. I'll stop there and open for questions.
Thank you. That was terrific. Dr. Nario, do you have any online questions or any questions yourself?
Yes, that was a great presentation. So a lot of this, we mentioned about the main function of the mammalian target of rapamycin. So this is a big, topic in relation to integrative cancer therapy. And this is something that has been shown to stimulate cancer. And in your discussion, there is actually in relation. I don't know if you touch on contraindications. How does a cancer diagnosis or a precancerous lesion of a patient gets affected by the administration of ketamine if this boosts mTOR?
Great question. So cancer is not a contraindication. In fact, we use it for cancer-related adjustment disorder diagnosis, depression, or even cancer pain. And I think you're referring to the mTOR as a general mTOR switch present in all cells in other organs, cancer in the liver, kidneys, lungs, whereas the mTOR in the brain is specifically targeted by ketamine through glutamate. So ketamine cannot activate the mTOR in any other cell of your body because it only reaches your brain.
So it's brain specific, is that what you're saying?
It's very selective.
Oh, okay, gotcha. That makes sense. Yes. It's a good thing because I was getting a lot of questions on that online. Another question for you would be when. So I don't know if you have this. A lot in our field, we are good friends with our compounding pharmacies, and as you were promoting, mostly these are commercially made medications, Spravato, the ketamine IV. In terms of effectivity, has there been a study or in maybe even your clinical experience about compounded versions of these ketamine? And there was a question in the chat also that they're using sublingual. So what are your thoughts on this in terms of your practice?
I'll answer that in two levels. One was the first question about compounding pharmacies. There's different types of compounding pharmacies. You have Class A, Class Bs. Some are bigger, some are smaller, some can cater to different states, some are local. So there's this great variety there. So, and depending on the state, they have to kind of follow regulations in how to make sure that the products coming out are clean, effective, and dependable. So I would say stick to like big name compounding pharmacies that are well established. I've encountered lighters, for example. There was a time ketamine there was a shortage. There was a shortage after COVID, ketamine. And I was trying to source ketamine and I couldn't find one. I called. Branded ketamine is only produced by 3 companies, Pfizer, Par, and Hikma. And during the shortage, they only prioritize hospitals. Okay. And the shortage was either the ketamine, the powder compound, or the actual vial. There's a time when the vial itself was a shortage. And so I was like, I can't open a ketamine clinic without ketamine, right? So that was a quick exercise. And I had to resort to compounding pharmacies too. The Lighters was a good brand that was reliable, as well. And so I would say stick to compounding pharmacies. And there are practices that rely on compounding pharmacies for their supply of ketamine because there are still some challenges even for like new starts to try to get established, have a vendor relationship with bigger companies. And some of them have gotten stricter after 2021 and the opioid situation. So there's a whole kind of story behind that. And, some of these big companies, McKesson, including, what's another one? McKesson is one, and a few others. They won't open new accounts, if you're going to order ketamine because of what happened. They're scared of what happened with the opioid thing. Now I think they're better. They have some compliance officers now. The second thing is, compounding pharmacies can provide IV, intranasal, cheaper versions than the intranasal Spravato. I think the intranasal compounded medicine is about $39, I think, which is like cheaper than the $1,300 branded one that's esketamine. And you can have it either racemic, meaning both right and left side, dextro and esketamine, or also just the esketamine. So they have that capabilities now. Most of the compounded ones that you see in the market are, that's flooding the market because of the current situation with some of the virtual ketamine oral at-home use is the troches, the square ones, sublinguals, and all that stuff. That is kind of like an ever-growing field and developing field. FDA just released a guidance against home use. I think it was last year. One of the biggest companies, I think Mindbloom, is undergoing litigation right now because of a patient that died of overdose after asking to discontinue his subscription, and they still send his subscription. So that's a whole kind of different developing story. But we do recognize the use of that space, and the American Society of Academic Physicians has not released a formal statement, against compounded oral formulations, and because it has a very specific use. But we don't recommend at-home use because it's okay until it's not. And what patients sometimes don't realize it's the risk, and so we're the biggest risk mitigators. And so doing it in a medical supervised setting. I met a guy that was from Australia, and he had practice serving a province in Australia with a radius of 4,000 miles. So he can't have his patients drive back and forth, and the oral ketamine was his way of helping the patients that really needed that treatment. But he had guardrails, so the first 2 treatments, you have to be in the clinic, we have to observe you. And the subsequent treatments, we'll do it by Zoom. My nurse is watching you, and you have to have a family member kind of be with you, so that we can respond if we need to. So those are there. Currently, they're coming up with some firmer kind of best practice guidelines, as well, specific to oral ketamine. But the general consensus among faculty and expert panel within the American Society of Academic Physicians is that we don't recommend its use at home.
Dr.
I think, go ahead, Dr. Bill.
Dr. Muscati, I think that if I mispronounced it, I apologize, has her hand up.
Dr. Salome?
Yes, I'm sorry. It took me a while to unmute. Thank you so much for this amazing presentation. So can one achieve therapeutic effects for depression using oral troches?
I'm sorry, I missed the first half.
Can you achieve therapeutic effects for depression using oral ketamine troches?
Yes, so it has been reported. It has been reported, and you can check it out in open evidence. The CanMat, the CanMat task force is a really good paper that reviews all of the data. But in terms of tiered evidence of efficacy, non-IV infusions are categorized as level 3 or level 4 categories, just because of the inconsistencies. There's so many reasons why IV is superior, but it's not that we don't see the efficacy in the oral as well. It's just weaker and inconsistent. And then you have to deal with sometimes the way it's formulated. The troches, one side is heavier than the others, and so that's been reported, as well. So most of the practitioners that use it are either using it as a bridge, patients who either lose insurance, as a gap until they can kind of get back on their feet. I know a practitioner that, her strongest advocate is oral in her clinic. She's up in Washington, Dr. Lucille Grande. And all of her published articles, she's probably one of the more prominent published articles in the oral use of ketamine, because her advocacy is access and with her patient population and whatnot. So it has its use, definitely, and it has its effectivity as well. But if you are after the best outcomes and you have the option, go to IV. If you have insurance, you can also go to esketamine.
And okay, thank you so much. And then do you believe that people with ADHD, because the neuronal pathways are a little bit different, probably some genetic SNPs in their metabolism of neurotransmitters, that they could have bad side effects to this? Just this is an anecdotal experience of someone I know, but have you experienced that? And is the dosing different for people with neurodivergence?
Great question. Patients with neurodivergence or ADHD patients, depending on the case, it can be very challenging to treat with. But it seems like ADHD patients, particularly those that are on ADHD medication, is a predictor of positive outcome. So they have better outcomes. So it was widely presented in last year and this year's conferences. Yeah, and that's been true of our experience too.
Thank you.
So they seem to fare better.
And could you just tell me the name of the task force again so I can look that up on the
Sure.
OR?
Canadian Network for Mood and Anxiety Treatments Task Force.
Thank you so much.
Yeah.
So just to reiterate, go back to the slide that you had on before. Your one of your key mechanisms of action of ketamine is to stimulate mTOR.
Yes.
Okay. Now we've done numerous episodes on longevity, where all of the practitioners on there, almost all of them, their main focus is to inhibit mTOR. So how do we balance that?
And I think you said it eloquently. You got to balance that perspective. I think you can just be like too anchored in one polar perspective, and have good understanding of that. I'm also very interested in that space. Longevity, anti-aging, mTOR, story of rapamycin. Really great story, getting that isolated from the bottom of the volcano on the Easter Islands from the Rapa Nui. That's why it's called rapamycin. And then almost didn't get discovered because the researcher their company got fired, and he just kind of stored that into his refrigerator until he found a new job and got the ability to research it again, that isolated Streptomyces hygrophithecus, and eventually isolated the rapamycin into the
I see you don't know. I see you don't know anything about this.
Yes, but it's a really, really great story. That almost didn't happen, right? And so I think that we can be global in our approach, but we can also be sophisticated in our approach, where we can have targeted means of activating mTOR. So in the brain, where you might want somebody who has either a degenerative dimension to their brain cells and brain mass, and there's been some wearing out or some damage or aging process, you might want the mechanisms that help repair, rebuild, restore these cells to get activated in a balanced way, in a sporadic, episodic way. And that's why it's kind of like that sweet spot. You don't want too much, you don't want too little. You want to wake it up when you need it. You want to slow it down when you don't need it. And in other parts of the body, like in the muscles or in the organs where you want to slow down aging, you can certainly activate that if you want to. But if you just lean hard on that, I think you're missing the other side of the coin. I think I love that phrase from Jim Rohn. If you want a safe life, we'll just put you in a corner in a chair. We'll bring you food. We'll bring you blanket. Where's the adventure in that, right? So there are points in your life where you do have to build, your muscles. You do have to grow your muscles, your brain. And I think one of your speakers, Ross Pelton, I think, right? He had a book on rapamycin and mTOR specifically. Alluded to that you can't use it for like kids. You can't use it for fetuses, because those are times in your life where you need the mTOR to be on because you're growing. And I think the way mTOR is being activated in the brain is beautiful via the ketamine, because ketamine will only activate it via the glutamate as the intermediary, which you don't have anywhere else in your body, right? So it's only produced in your brain. So it's a very specific kind of target to try to turn on the brain if you want those parts of your brain to be turned on.
I think Dr. Boco hit it on right on the head, that it's a balance. We can't really suppress mTOR permanently. The thing there is, as the opposite enzyme for, and I want to quote Dr. Halasa, the AMPK pathway. So AMPK pathway is the one that actually utilizes the energy of our carbohydrates, fats, and even proteins. And then mTOR builds it up. to create tissues for us to repair. So this is something that is a universal balance in life that we have to maintain. And that's why the question about the cancer a while ago kind of is pertaining to that same answer, that it's really more targeted to the brain rather than more of a systemic induction of mTOR stimulation. So yes, again, balance is the key here. So in longevity space, we have to remember that we can't overdo a specific therapy to the point where it disrupt the equilibrium.
Right. And well, there's I put in the chat there our lecture that we did in November of 2024 on mTOR and rapamycin, just as a reminder. A certain someone here gave that talk at AMMG, and there it is. So anyway, apropos about nothing. The next question: do you give midazolam before ketamine?
Good question. So it's a whole topic in itself. It has its uses. I do sometimes. It's great in blunting the high intensity effects of higher doses. The original protocol for pain protocol was so unpleasant for a lot of patients because it's a longer duration. Patients are exposed to the higher dose. The original protocol is called the O'Cohen protocol. Stanford refined it, added midazolam in the front and in the middle, just 1 milligram sprinkle. Recovery was beautiful. Patients are no longer vomiting. Coming out of it is so much better. They're able to tolerate higher doses better. So yes, it has its use. It's not a universal thing that I use in all patients. It's particularly extra useful in patients that come in and they have, extra high anxiety or panic attack. We have it at the ready in case patients have it mid-treatment. It's rare that I have to use it, but in some cases, it's a good thing to have it, in your armamentum, because if I give it beforehand, it just helps the patient tolerate it better. As a corollary, the Harvard data, what I didn't show there was that almost 86% of their patients received IV lorazepam. And that was very high. That's very, very high. It's almost all the patients that they get after a certain point will receive lorazepam. And the reasoning by Dr. Kreitzer is that it helps them with the higher doses of 1.3, 1.5 mg per kilo. And a lot of patients are also anxious. And so when they get to the higher doses, the premise is that they get more of the medicine, more of the therapeutic effect, better tolerance. So yes, I do have midazolam, but I don't use it universally. It's very targeted.
Okay. For those of us not going the IV route, using troches, what is the maintenance phase like after 6 weeks? And Stefan Hartman had an answer, but we'll get it from the master here.
After 6 weeks, what I usually tell patients is I assess where we are. In the first 6 treatments, I'll have a good sense of whether a patient is an early responder, because I'll see the decline in their scores in the first 3 sessions, or they are a late responder. So they're on the back end 4, 5, 6 number of treatments. Mm-hmm. And generally, older patients 65 and above are late responders. And it's probably something to do with their physiology. But I have seen patients that are early responders as well. And then once we finish the 6, that's when I can have a conversation with them to continue. Because if I see a response, there's value in continuing what's called weekly boosters for 4 weeks. It does 2 things. One, it locks in the benefit that we got. Sometimes it further pulls it down, in terms of the response. And it extends durability. So 1 IV infusion of ketamine has been shown to have a durability of about 7 to 10 days. Durability means, how long the response lasts. And even on the first RCT trial by Berman, he's demonstrated that it can last 1 to 2 weeks. If you complete the 6, it's been shown that it can extend it to 5 to 7 months. If you add 4 to make it to 10, it can extend it to 12 months in some patients. So that's really the value of that. So once they finish that, if they can finish that, for some patients, it's kind of cost prohibitive, but that's the most ideal recommendation I would give them. And then it becomes kind of like individualized for IV.
Are we allowed to ask, what is the cost?
It varies. So the out-of-pocket cost, at least for our clinic, is $600 per infusion.
Okay.
Yeah.
All right. Dr. Anchetta asks about hypersalivation. Salivation. Hypersalivation. Any issue with that?
So higher doses has been associated with hypersalivation in the mucosal tracts. Very, very high doses have been associated with laryngospasm as well. So those are the things that you have to kind of be prepared for. But in general, in our experience, that has not been a problem
What do you
at
feel,
the
Erwin?
dose levels that we're operating.
Okay. Dr. Rosario from the Philippines says greetings. He's interested to know if he can send his USA vets and clients to you. And
Thank you. I mean, that's
and he said he had to go, can share the recording. We'll get in touch with him, Dr. Nario, and make sure that he gets a copy of this, okay?
Yep. Sure.
Okay. Can you achieve similar therapeutic effects with oral trochets? I think you answered that one. And can you elaborate on the protocol with intranasal ketamine and how effective it is compared to IV?
yes. So the schedule. There we go. Only difference between IV and intranasal S-ketamine is that first calendar, which is the more frequent induction phase, is 8 treatments instead of 6. So instead of 3 weeks, you just add another week. And then you still do a weekly booster for 4. And then for maintenance, they have to stay on it. And the maintenance schedule for S-ketamine is between once a week to once every 4 weeks. And the right frequency is the one that keeps the patients under control. The cool thing is that we've been following these patients for the past 5-6 years, since 2019 when FDA approved it. We usually see this dramatic response in the first month. As long as patients are good and compliant in maintaining their maintenance treatments, they don't relapse, which is amazing. This is actually an old slide from last year, and there's a new slide now for 6 years. So it's been great. So at least for us, we offer both. And if patient wants to get the response quicker, faster, IV is the way to go. And while we're waiting for prior authorization from insurance, if they have insurance, we're working on that. By the time they're done with the IV, we can switch them to Spravato and have it on maintenance, or S-ketamine, sorry.
Have you had many like codes or medical emergencies resulting from this?
No. So all not from our experience. I think the most I've had is a stable SVT from an AFib patient, and so went up to like 150. So we're doing like,
I know you showed it that you need a lot of resuscitation equipment around, don't you?
we do have a crash cart, we have O2, we have AEDs, and so we're trained ACLS to respond. Cool things that we have data from over 450 ketamine clinics who are in part of the network of the FDA REMS program. And so you have to be FDA REMS certified to be able to provide S-ketamine, the intranasal spray, to the patient. And there's only been 2 minor adverse events. There's no deaths, there's no heart attacks or anything like that. And both involve O2 desaturations. One was in a very obese patient with obstructive sleep apnea requiring tactile stimulation. The second one was in a patient that took benzos and opioids and muscle relaxants before the treatment and didn't tell the provider, and obviously that's a no-no. We usually tell patients to give us a window of about 12 hours before treatments to avoid opioids, benzos, and a few other things.
I actually took the IPI course myself. I got about halfway through and said, I don't think I want to deal with this.
The risk is low, but it's not zero. Okay. And in IV, there's been reports, that's S-ketamine. In IV, it was presented this year. There's a big clinic in New York, Ember Clinic. They have 5 clinics across New York City, and they've had I think 25 infusions over the course of the past 4 years. So they've had like less than 1% where they've had to send to the emergency room, call 911. And if you do enough of these, it's just a matter of time, so to end up, seeing some patients can have arrests, even if they're not in a ketamine clinic. They can certainly have one, in your clinic, as well.
I know they seem to emphasize that though in the IPI course stuff. That's just about every lecture was at least 15 minutes of an hour lecture was that, and after the first 15 or 20 of them, and I'm not so sure I want to get involved with it.
Don't get discouraged. Don't get discouraged.
Any idea why naltrexone would block the antidepressant effects of IV ketamine?
So naltrexone is controversial. Naltrexone challenge is the reason why ketamine is class 3. So even the classification of ketamine into a class 3 medication was very controversial, and you can go into a rabbit hole, deep dive into this. It's a whole kind of storyline. The reason why ketamine was class 3 because there's a study that showed a challenge, and there was a partial kind of blockage. So it was given before the treatment, and it seems to have a partial blocking capacity for ketamine.
Was that 50 milligrams of naltrexone?
I can't remember the dose.
Or was it the low? It wasn't low dose naltrexone, was it?
Yeah, I can't remember the dose. But naltrexone itself, in further studies, at least as long as we give ourselves like a 6 to 12 hour window, we're able to get it there and do its thing, in the brain. So we really just need a window to introduce it, activate the glutamate enough to wake up the mTOR and not overexcite the mTOR, just enough to stimulate the neurogenesis, and then come back again, another day.
Okay, our venerable ex-Marine is back after a long absence, and he asks, the VA only approves outside Spravato at this time, and IV is not authorized. Is that correct?
It's half true. So the VA does cover Spravato through the CCN, Community Care Network, and the VA also covers IV ketamine through the VCA Veterans Care Agreement. They don't hand out Veterans Care Agreement contracts. So VCA is a very separate contract. It's kind of like a carve-out contract that they identify there's a need in the community, and you're going to be one of the clinics that will kind of meet that need. So we do have two contracts with the VA, a CCN contract and a VCA contract. So you can, if you have a clinic, you can apply to both. And the IV itself is covered through the VCA contract. There is a national guideline, and sometimes there's an awareness issue, like some of their VA doc psychiatrists or PCPs are not aware that the veterans have this access. The clinical practice guidelines is available at a national level. So these are national guidelines of the VA. And usually when patients call us, they're from the VA and like, yeah, just get a referral from your psychiatrist. And if we usually have a ready pamphlet telling them that these are some of the information. If your doctor is not very aware, certainly give this to them, and then they can kind of send a referral to their referral clerks, or MSAs we call them. It does help if the local region kind of director that approves all of these outside referrals is aware or is an advocate. We're fortunate in the Sacramento area, the director of the VA at Mather, Dr. Gellerman, is a strong advocate, for this. So we've never had any problems. So turnaround times, even VAs that are new to the area, traveled from out of state or something like that, when we give them guidance, usually within 2 to 4 weeks, they're already seeing us and getting treatments.
And the VAC, is that Veterans Administration Care?
VCA, Veterans Care Agreement. So it's a second kind of contract. You can certainly apply for CCN through TriWest, right? So TriWest, which is kind of being serviced by Blue Shield, that pathway can only cover esketamine.
Okay.
So you cannot send claims or bills for IV treatments for that. So you need to get and apply a second contract for a VCA in the same manner that you apply for the CCA and just ask, hey, can I get a VCA for providing IV ketamine for my patients?
And the VCA goes through TRICARE also?
No, it's directly to the VA, and the funding is directly to the VA. It's not through TRICARE.
Okay, thank you.
Yeah.
Okay. Dr.
And I
Nick,
can have more one-on-one on that if you have more guidance. There's some nuances to it.
Okay.
Help guide
Dr.
you.
Naria has the study was 50 milligrams of naltrexone.
Yes, thank you.
All right. Dr. Naria, you got any more questions online?
No, question for me.
Yeah.
Because I see a lot of patients here, our Burning Man groupies. So if somebody's actually doing ketamine therapy and behind the scenes, they're doing ayahuasca, they're doing ibogaine, they're doing all these things. I mean, is this something that you've encountered before? And how do you handle these situations? I do have these extreme patients who does this. And what would be the best advice for these type of population?
Specifically to Burning Man participants, I have not encountered any. I did have some encounters with patients who have tried or currently are kind of either trying mushroom, psilocybin, and a few other compounds, MDMA. MDMA and psilocybin are actually trying to get FDA approval right now. They finished their phase 3 clinical trials through the MAPS program, which was actually great, but due to some critique in study design, was rejected by the FDA. So it's not an absolute contraindication, for us, but I always, guide the patients that safety first. So I want to make sure it's as boring as possible and as safe as possible for you. Second thing is I want you to get the most of what this medicine can offer you. And mixing it with all of these other medicines can make it, can blunt it, can block it. We don't know. I don't have that evidence. I don't have that data. So it's resource intensive, it's time intensive, emotion and energy intensive. And so I ask the patients, if you're going to commit to this, I'm committed to you. I want you to get the most out of these treatments. And my recommendation would be at least to abstain from these treatments. So at least we're clear whether you're going to respond that this is from this treatment. So, but first we approach it with non-judgment and radical acceptance. That's one of the core principles we apply in our clinic.
Okay, great. Okay, Dr. Nario, anything else?
All the questions are checked out. Awesome presentation, Dr.
Okay.
Erwin.
Thank you, Dr. Boco, so much. And you said you had a whole nother topic. How does April 28th?
You got baited. You got trapped.
You said that with midazolam was a whole another topic. April 28th is open. Not that we want to put you on the spot.
Thank you for the invitation. I really enjoyed.
Thank you. It was great.
Group. This esteemed group. Anything I can do to kind of increase the dialogue, increase the awareness, that can positive effects.
Spread the word. That the link you have is we're here every week. We've been here since October of 2020. And next week we have a true pioneer in the world of bioidentical hormone therapy, Dr. Eldridge Taylor. He was actually one of my teachers way back in 2000, got to be 2006, 2007, and he's still at it. And so I think, if you're at all interested in hormone optimization, I mean, he's the man. Thank you so much, Dr. Boco. This was great. We'll be sending you a video and the participant list here. So if you have any offers or courses or anything that you're interested in and we're doing, you can get in contact with them. We're here every week. You're more than welcome to join us. And we'll probably be annoying you later on in the summer. Okay.
Thank you, Bill. Thank you.
Right.
I was looking at the chat. I don't think I answered it directly, but going back to the question on ketamine effectivity, the response rate is about 65% compared to around the 80% of the IV ketamine. And so they complement each other still.
Great. Dr. Naria, do you want to say something about the credits for the Homeopathic Board of Medical Practitioners?
Yeah, so we're now gunning for more credits. So we did CME credits for our presentations. Now we're going for homeopathic credits. So as we expand our coverage for integrative medicine here, we are now going to go through the state to get actually our lectures here in AOSIM to be hopefully accredited. So we'll find that out soon. So just more things to come for the integrative world here in Nevada
Okay.
and
Yeah.
for everybody.
I'm not sure what happened to Dr. Halas's CME provider, but if I don't hear anything in the next week or two, we're going to start looking elsewhere. So,
Yeah, but we're going to be hopefully getting this one.
okay. Good deal. All right. Anybody have any comments or questions? The folks in the Philippines, thank you. It's as welcome as always. It's great to have you. Dr. Boco, can't thank you enough. And if that's it, we'll say good night and good hockey for now. And we'll see you again next week. And like I said, we have a true pioneer next week. Spread the word. So we can expand our reach. Oh, and we're starting to kick the tires for the next live conference, by the way. So we'll be we'll be working on that. I've recovered from the last one finally. So
We're ready for another round, huh?
yeah, well, I have a birthday on Thursday, so the more mature I get, the harder it is to recover. So
Get a brick, slam it on your head, huh?
that's right. Okay, everybody. Thank you so much. And we'll see you again next week, same time, same station. And over and out.
Thank you.
Thank you, John.